Hello, good evening everyone, and welcome to the EUROGEN webinar series. And actually this is the last one of the year for 2022, but we really hope that you'll all join us. We've got some really interesting ones booked in already for 2023, so please keep an eye on our schedule. So for those of you who are not so familiar, we are one of 24 European reference networks created by the European Commission in 2017. And basically we all aim at helping patients with rare and complex diseases, where the expertise to help those diseases is sometimes rare itself. We do a number of joint collaborations. We in EUROGEN, we deal with rare urogenital diseases and complex conditions. And we're now a network of 57 hospitals all collaborating together. Some of our main activities, well, we have education and training programs, and actually this very webinar was born out of a very successful exchange program where the whole multidisciplinary team from Bremen came to visit us at Radboudumc University Medical Center. So it's really great to be able to share experience and knowledge in that way, and that's one of the things that the ERN funds. We also produce clinical guidelines together. We have other training activities. We also collaborate and give virtual advice using a secure clinical patient management system. So please, I would strongly encourage you, any of you out there who are struggling with a difficult or complex case and you need advice about the surgery or aftercare, please let us know. We can arrange it fairly quickly. It's free of charge and we're delighted to help. So please help us make more use of our CPMS. We also have a registry which is under development, and that's a very exciting long-term development for us all. So without further ado, this evening's webinar is on anorectal malformations, the multidisciplinary treatment of continence disorders. And we all know how important the multidisciplinary aspect is. We have 4 presenters, 3 of whom are from Radboudumc University Medical Center. We have Danielle Weenink, who is a nurse practitioner. We have Wies van Aalst, who is a pediatric psychotherapist. And we have Aukje Aerts, who is a pediatric psychologist. So apologies for any mispronunciation there. And then finally from Bremen, we have Eberhard Schmiedeke, and he is a pediatric surgeon. So thank you all so much for sharing your expertise with us, and we really look forward to hearing your thoughts on how to treat these complex patients. Thank you very much. You have the floor, Eberhard.
Good evening, everybody. Also from my side, thank you very much for joining and giving us the opportunity to share with you this groundbreaking approach, which gives physiotherapy and psychology the important roles they deserve in ARM follow-up. And thank you very much, dear Michelle, for your friendly introduction. We have no conflicts of interest to report, be they financial or non-financial. This is our agenda. First, Luz will give us an overview about your current thoughts to the subject with some short questions. And afterwards, we will present MBT to you from our 4 different professional perspectives. Finally, we plan to have 15 minutes for your comments and questions. If questions arise later, or for those looking at the recorded webinar, please send me an email, a slide, and we'll answer as soon as possible.
This is the first poll. We want to know what your role is. So are you a parent, a nurse, a psychologist, a pediatric surgeon, or something else? And you can now vote. Thank you. What I see is that 43% is a pediatric surgeon and 17% is a nurse. Thank you for this. And the second question, it's a statement. Young people of 12 years are too old for the MDB. Do you agree or do you not agree? Please vote. I'll close the poll in 2 seconds. And we see that 90% of the attendees doesn't agree with this. Next question, children that are 2 years old are too young for the MDB. And I'll close the poll. This is not so evident as 61% doesn't agree. And the last question, children who start with rectal washouts do not need behavioral treatment anymore. I agree or I don't agree. Please vote. I'll close. And we'll see that 93% doesn't agree with this question.
So good evening, everybody. Welcome to this webinar about multidisciplinary treatment of continence disorders in anorectal malformations. We first have to answer the reasonable question why multidisciplinary treatment of anorectal malformation patients is not a luxury treatment, but of utmost importance for the outcome of treatment in anorectal malformation patients. Simple answer is that the best surgical procedure in the world and surgical follow-up is not enough to tackle the manifold problems coming with the malformation. The role of the nurse practitioner starts a long way before the actual multidisciplinary behavioral treatment. We are involved with the child and parents from birth until adulthood, where we advocate the patient's and family's interest. We are the first and regular point of contact. We get to know the child and his parents from a biopsychosocial perspective and discovering strengths and limiting factors. Also, the nurse practitioner is a healthcare provider that has a broad medical and nursing knowledge of the child's condition and is able to view the patient from both aspects of care and cure, is thereby able to counsel the patient to the fullest extent possible. During the healthcare process, we seek to create the most optimal conditions for managing the child's condition and the process toward continence. This includes the awareness of preventing negative stimulations to the pelvic floor, like painful dilatations or unnecessary rectal touché, severe diaper rashes, hard painful stool, and possible traumatic rectal washouts, which all can cause avoidance of defecations. During the follow-up on the patient in an outpatient clinic, we discuss the patient's situation from a biopsychosocial perspective. We evaluate the physical condition and possible morbidity, but also psychosocial functioning, how the child, but also the parents, cope with the condition, what are strengths and limiting factors, how things are going at school and with friends or sports in relation to the child's condition. We identify potential needs or problems and assess whether we can directly start an intervention or treatment, like stool softeners in case of hard stool, or consulting a dietitian for optimizing consistency of stool, etc., etc. When continence becomes a factor with child or parents, or if we think multiple factors are contributing to defecation problems, we discuss the case in an organized multidisciplinary meeting together with the pediatric surgeon, psychologist, and physiotherapist. The nurse practitioner indicates that psychological and physical therapy support is probably needed. In cooperation with the pediatric surgeon, the nurse practitioner will determine whether further examination for physical causes is indicated, for example, an Xray or contrast study. During the multidisciplinary treatment, the nurse practitioner has telephone or email counseling on a regular basis. In cooperation with the pediatric surgeon, we prescribe or adjust medication as needed as support in the treatment. There's also support in the form of aids for continence, like incontinence swimming suits or special panty liners. The nurse practitioner has a regular consultation with involved disciplines like the psychologist or physiotherapist to ensure or optimize continuity of care. Sometimes a joint outpatient appointment with the psychologist or physiotherapist takes place. Consultation may also take place with school or external healthcare providers if involved. During the evaluation, results and progress are discussed. Sometimes the defecation problems reached an acceptable situation for child and parents. Sometimes the child or parents are not ready at the time, and the nurse practitioner can consider a support bowel management to achieve social continence. The patient stays in the follow-up until adolescence and eventually receives transitional care. For the select group of patients with anorectal malformations, but also Hirschsprung's disease, the nurse practitioner is involved in the MBT professionally as well as functioning as a case manager. The nurse practitioner engages in identifying and organizing needs and problems, coordinating multidisciplinary teams to tackle the problems, and performing continuous evaluations. This all in collaboration with the pediatric surgeon, psychologist, physiotherapist, and sometimes dietitian, social worker, stoma nurse, pediatrician, and external network. By this multidisciplinary approach, we have the intention to reach, optimize, and continuity of care. A focus on prevention, elimination of barriers to care, and self-management are integral strengths that nurse practitioners contribute to help sustain optimal target outcomes in care. A good comment over coordination, regular consultation, and collaboration with other professionals lead to implementation of a shared care plan. It's also a goal for patients to develop the confidence and skills necessary for successful management of their own chronic illness. And this approach might save medical time and costs by early detection and treating chronic defecation problems as early as possible. Frequent medical visits and invasive procedures can possibly be reduced, and more important, the possible consequences such as psychosocial, like emotional and behavioral problems, and a poor quality of life subsequently are prevented, so we hopefully have a happy patient. And now I hand over to Eberhard.
Thank you very much, dear Danielle, for this impressive portrayal of the crucial role the nurse practitioner and case manager has in the treatment of ARM patients. I will now clarify the role of the pediatric surgeon in the team. She or he has to understand the indications of MBT and how to support it. A lot becomes clear when we take a look at the physiologic development of continence. Unfortunately, my slides don't want to move. No chance. That's the way it goes. Okay. The physiologic development of continence.
To share your screen again.
I'm sorry. Now you can see it?
Yes, great.
Wonderful. In the newborn, the rectum for the first time gets dilated with stools. This stimulus triggers the reflex answer of an evacuation, leaving the baby relieved. During potty training, the child learns to consciously perceive the rectal filling and to delay the reflex answer until it reached its potty. This increase in self-control is extremely important for the child psychologically. In ARM patients, this intermittent rectal filling often is missing, either because of a colostomy or because of chronic constipation. And of course, at potty training age, these children cannot develop the conscious control of a reflex which was not properly established before. Instead, we often find overflow fecal incontinence with painful nappy rashes. On top of these learning problems, negative stimuli to the pelvic floor, like painful dilatations, as shown in this picture, or ulcerative nappy rashes, contribute to the unwillingness and inability of the child to defecate properly. In children with such a history, we often hear of and see defecation avoiding behavior, and paradox contractions of the pelvic floor when they try to defecate. Similar problems can be observed in the huge group of otherwise healthy children who develop constipation at age 3 to 4 because of one-time painful defecation due to hard stools. During regular surgical follow-up, both the nurse practitioner and the pediatric surgeon, as we heard, identify those patients who obviously have problems to develop continence at normal potty training age. We ask actively for painful stimuli to the pelvic floor during dilations or nappy rashes, especially following colostomy closure, and for stool withholding behavior, avoiding postponement. The parents usually observe this very well. The final decision to offer MBT is taken by the complete team, as mentioned. Before we can start with MBT, we have to make sure that coprosthesis is relieved. Ultrasound investigations of the abdomen are absolutely necessary every time you see an ARM patient. The transverse diameter of the rectum will tell you whether there is coprosthesis, what change you have since the last time you saw the patient, and to what extent. Severe stenosis of the neo-anus, of course, would not allow normal defecation, but fortunately is quite rare. It can be assessed in a non-invasive way by simply asking for the diameter of firm feces. If it corresponds at least to the diameter of the patient's thumb, the neo-anus is wide enough. Transanal bowel management can be easily combined with MBT. During vacations, the children can stop the irrigations and assess the grade of active continence they are able to achieve. Sometimes the begin of bowel management together with MBT can be indicated to relieve the child's psychosocial stress caused by fecal incontinence. Yet many children are so traumatized that transanal bowel management is strictly refused by them. We want the child to regain trust in its own bodily resources and also trust in the medical community. To reach this goal, we should avoid re-traumatization, especially to the pelvic floor, as already stressed by Danielle Weenink. I repeat it here because it is so important. Once the training started, the pediatric surgeon, of course, has to carry on the treatment of constipation and the care for associated medical problems, especially in the urological and neurosurgical realm. To sum it up, MBT is indicated in patients with functional disorders of defecation and micturition, which are frequent in ARM patients, especially after painful stimuli to the pelvic floor. Thank you very much.
Thank you, Eberhard. As pediatric physiotherapists, we have knowledge about children's motor development, among other things. As a pediatric pelvic physiotherapist, I have additional training in pelvic floor functions in relation to motor development. For proper defecation, a number of things would be important, such as recognizing the signals from your body and responding to them, being able to properly relax the pelvic floor, combined with the right pushing technique, and being able to remain on the toilet for a while. That would mean that if you master these skills, you could be potty trained. But it's not that simple. Through research and experience, we know that continence requires not only physical, but also cognitive skills. This is also the reason I almost always treat children together with the psychologist. That is why we work according to this model, created after scientific research. the EUROGEN webinar that is about quality of life in patients with ERN discusses this model in more detail. We always start the MBT with knowing why, for both children and parents. Knowing why is an important point in creating support for the treatment program. It can help understand why, for example, bowel treatment is important. We use drawings of booklets to give the child and parents information. Daring is especially in this patient group important due to possible unpleasant experiences in the past in the pelvic area. You see, some children prefer to avoid anything that has something to do with their pelvic area or anus. It is important to overcome this in order to be able to move on to the next step. The step of wanting is important to get reciprocity in the treatment relationship. Both parents and child must be engaged and willing to follow instructions. To be able to defecate on the toilet, it is important to have the ability to relax your pelvic floor and push with the right technique. Especially relaxing the pelvic floor can be difficult in these children due to past painful experiences. As pediatric pelvic physiotherapists, we can work on actively relaxing the pelvic floor. But often we see that children with an overactive pelvic floor in general have difficulty relaxing. This is reflected in the way they move and how their body builds tension when they are anxious. When we enter the doing phase, the results such as no more accidents is not yet the most important thing. The most important thing would be actually going to the bathroom and applying the tools obtained up to that point. And also developing a schedule that includes the times when the child should go to the toilet to defecate. In this step, we think it is essential to teach the child and the parents that accidents are still part of the process. For persisting of what has been learned, it is crucial that there is a schedule that is adapted to the child and his family. In this step, the newly learned behavior has to be normalized in everyday life. This last phase is often the most difficult when it comes to retaining the newly learned behavior. Summary about the MBT. In fact, it is almost never a monodisciplinary course. It varies over time what the child or parents need. This can sometimes cause one discipline to be more involved than the other. But the strength of MBT is the continuous consultation with child, parents, and other caregivers as to what the best plan is at that moment in time. And as you can see from the drawing, we try to give both the child and parents tools to be able to take steps forward even after a difficult period. We try to make the child and parents aware of the fact that it is normal that things sometimes go less well, but that they have the knowledge to turn this around. And now I hand over to Aukje.
Yes, thank you, Wies. As you have heard a couple of times during the talk of my colleagues, we talk about a treatment plan and not a training. This is because every developmental stage in the REM will play a different role and has a different effect on the quality of life of the child and family. Because of this, every phase needs a new treatment perspective, considering the development of the child and parents, and often a different approach from the team and thereby a new treatment plan. If we call MBT a training, the risk is this implies it will succeed or it will fail. For example, when a child needs a temporary break from continence training because of great distress at school, it may appear that this is the end of the training and thereby the child failed. Obviously, this is not true, because right now the child has other needs, for example, support at school. We hold on the MBT, support the child at school, and then continue again to the continence training when the child and the family are able again. We carefully match the program with the child and family needs at that time. This is another reason why we call it a program to emphasize that there are different treatment possibilities, considering what does this child and his family or her family needs with this disease in this particular phase and with these symptoms. As a psychologist, we are part of the MBT team, and that's because of the biopsychosocial model we work with. as Danielle already told us about. That means that we do not only see the problem from a biomedical perspective, but we take into account that the social and psychological factors as well. For example, social status, traumatic events, EQ, or developmental problems. As a psychologist in the MBT team, we emphasize that the arm disease interferes with normal development of the child or adolescent and the family. And of utmost interest is that the development of the child interferes with any outcome of treatment of arm. Going to school asks for specific attention regarding continence in children with arm. In the Netherlands, children go to school at age 4, and they expect the child to be continent, which is hard for every child, but even more for a child with REM. And some children are very young in the development, and that makes it hard to meet with the demands of continence. For example, being able to sit on the toilet for a while or give attention at physical signals, even at older age. For parents, the incontinence can have a great impact on the emotions and feelings. They can feel like they failed or get very angry. And it also has also influence on their daily lives and may cause great distress. For example, in the Netherlands, parents need to arrange their help at school regarding incontinence of a child. This means that they need to go to school 2 times in the morning to change diapers. This has an effect on their ability to go to work. Because of this interference, as a psychologist, we always keep in mind, at what stage is this child and his or her family in the development? What are the needs of this child or adolescent and their family in this particular phase with this disease? And how can we provide them as a team, medical as well as psychological? This means we give advice or psychoeducation to the team, and they will take this to their outpatient clinic. Also, we participate during patient visits to the outpatient clinic, and we participate with the physiotherapist in the toilet training. Also, we see children and their parents in individual therapy. Okay, there are 2 critical phases when we explicitly are involved with the child and the family. This is the postnatal period and around toilet training. In order to improve psychosocial care, we introduce ourselves right after birth of the child with REM. This makes us more approachable, and we can screen for psychosocial problems and trauma. Also, we keep in touch to give psychoeducation and to talk about their sometimes traumatic experience, to prevent severe trauma, or to be able to react and arrange the right psychosocial care for parents if needed. Another important phase when a child is ready for toilet training. We focus on how to decide when, how to balance the medical and psychosocial conditions, and how to come from intentional to actual behavior, as Wies already told us. The aim is always to stimulate and endorse the self-efficacy in children as well as in their parents. Wies already told you about this toilet training, and if you want to learn more about this, I would like to refer to the EUROGEN webinar about quality of life with patients with REM from the 25th May 2021. I would like to emphasize one aspect in the postnatal period. Especially in this early stage, there's one important task for parents that has to do with attachment, but I don't have time to talk about that right now. But the task is they need to keep their child safe and comfortable, mentally and physically. When the child needs an operation right after it when it's born, that's very stressful for parents. They must allow their child to be physically uncomfortable in order to keep their child safe. This task is almost impossible. This causes pain and distress by parents, which needs attention. What I hear in my daily clinical practice from almost all of them is that it makes them very insecure and they feel guilty about their parenting. It helps if we keep this in mind and help parents by addressing this. It also helps if doctors recognize this. They do not have to solve it, but it helps if they recognize the emotional impact making the child uncomfortable. Apart from the psychological needs of parents, another important factor is to contribute to the self-efficacy of parents and child. In order to reach the self-efficacy from psychological perspective, in summary, we focus on trauma, or be aware of trauma, to reduce distress, to handle the emotions, to take care of the family, and in the toilet training, remembering doing is much more than knowing. And also we are aware of risks for coping problems. So that's in summary what our psychological task is. In the end, it's important to remember that children and family differ in their resilience to deal with ARM and its treatment, and they also differ in the need for additional care. So they all get a different treatment plan, but always the patient and their family in the center.
Excuse me, my PC is crazy. You can see my slide and hear me? Wonderful.
Yes.
Okay, both our groups from Nijmegen and Bremen published results. I shortly present to you our first results in Bremen concerning two parameters which we learned in Nijmegen and which turned out to be very helpful in everyday practice. The first is the percentage of feces reaching its target, the toilet, and not to spill the underwear. On the average, it went up from 30% before therapy to 99% at the end of therapy and stayed stable over the observation period. The second is the number of serial clean days in a row. The improvement looks less impressive here, yet you have to keep in mind that the amount of feces in the underwear is far, far lower than before therapy, as shown on the slide before. Our Bremen numbers compare with the ones from Nijmegen. The limitations of our study are very low patient number and that we testify to our own success. I tried a lot to find sufficient funding and manpower for a treatment-independent, multi-center study of the effect of MBT. Unfortunately, I was not successful. I hope that all of you now agree that psychology and physiotherapy play an important role in treatment of ARM patients from birth on, even before potty training age. They can be helpful in puberty too, but should begin far earlier. And transanal bowel management can be easily combined with a program for active fecal continence. Please take home the insight that an anorectal malformation causes not only somatic defects, but also severe functional disturbances, which can be aggravated by painful experiences, especially in the pelvic region. And they can be successfully treated by a multidisciplinary approach, including psychology and physiotherapy. If the children learn to let go properly, the tightness of the sphincters becomes less determinative for their fecal continence. If ARM patients are treated in your clinic on a regular basis, we strongly ask you to offer to them this multidisciplinary aftercare by establishing a MBT team in your clinic. Unite the various professions, set the proper frame of knowledge and funding, and then turn to us. We will help you get started as good as we can. We have a track record in this. Bremen was the first clinic worldwide to adopt the Nijmegen approach, and through several seminars, we were able to help other clinics in Germany to set up teams too. Some others tried but failed. To establish proper multidisciplinary follow-up is not an easy task, especially with the low case numbers we have in most European clinics. Please watch therefore also our respective webinar on centralization. We thank you very much for your patience and attention. Here you can see the webinars we refer to and my email address for your future comments and questions. And now we are looking forward to take your actual contributions.
Thank you very much, Eberhard. We have some questions. I send them to you. I don't know if you are able to see them or if I need to read them out loud.
It's better to read them out loud for all the attendance of the webinar, for all of the team. At the moment, I see only my slide. Here we go. No, at the moment, I can't see a slide.
No problem. Then I'll read them out loud. The first question is, why do you prefer abdominal echo, ultrasound, and not the abdominal X-ray?
Oh, this is very clear because there is no doses of X-ray which is not potentially a hazard. There is no low dose of X-ray which might not cause severe problems like cancer later in life. If you look at the amount of radiation someone receives with the North American protocol of X-ray of the sacrum, right, the child is born, a VCUG, a pressure colography, and then you make at 4 years you make a bowel management week with a daily abdomen X-ray. I ask our technician, there are people who know epidemiology and X-ray, and they tell you, okay, if he treats 100 children this way, one of them will die of deadly cancer later in life because of this amount of radiation. And this is only the deadly cancer. So we as pediatric surgeons, we don't see the consequences. The patients have to suffer from multiple X-rays, but the patients have. And we have the scientific data to know that X-ray must be avoided whenever possible. And so ultrasound, we use ultrasound. That's it. One gets used to it. It's not that difficult.
Very clear. Another question is, at what age do you start treating constipation in kids?
I think this is a question for Danielle, isn't it? Danielle, anybody there?
Sorry, in the microphone. At what age do you treat constipation? Well, you have to treat the constipation at every age, even when a child is 1 year old. It's very important to avoid negative experience with hard stools. So when a child is like a baby, you start with laxatives. And when children are older and the time is there for them to start a practice with the MBT, you also get together with the physiotherapist and the psychologist, but obstipation, you always treat it.
Yeah.
Thank you.
And
There's
we
another
also use, may I just add, we also use polyethylene glycol as a harmless stool softener, which is not a stimulative laxative in babies. It's not officially allowed, but it works, and it's better than lactulose and this kind of stuff.
And there was another question, if in the neonatal period, if incontinence is considered normal. I think that's a short question.
If Wies, do you want to answer, or Danielle?
Luz, can you repeat the question again?
That's in the neonatal period, is incontinence considered normal?
Yes, in the neonatal period, incontinence is normal. Yes, that's true.
Great. And I think another question maybe to Wies, and how do you predict that pelvic floor therapy may improve outcome?
Can you repeat the question?
Yes. How do you predict that pelvic floor therapy may improve outcome? So I think, how do you select patients?
Yeah, that's very hard to predict because
we see children where the pelvic floor looks good and coordination is okay, but sometimes there are other factors that influence the chance of getting continence. So even if the pelvic floor is all right, looks good, and children have good yeah, good prognosis. Sometimes we see it still is very hard to obtain continence. So it's good to look at the pelvic floor, and it's good to see if you can influence the pelvic floor to actively relax the pelvic floor. But sometimes it's now very in very few times it is only the pelvic floor that influence the chance on continence.
May I please add, in the newborn, you can already quite check what the prognosis for later continence is, the complexity of the anorectal malformation. Is the rectum ending high or low? And is there a sacral dysgenesis or a tethered cord or psychosocial problems like in a syndrome? So sometimes people come, parents bring their child to our treatment, and you look at the medical data and have to say, well, the prognosis for active fecal continence is very low, even 0, and I'm quite honest about that. But nevertheless, we often start the treatment because the physiotherapy and the psychological counseling is so precious, and the children develop so wonderfully, and it's so helpful for them to get independent and self-conscious, etc., that in the end they have a huge benefit from the training, although they did not reach active continence and still have to do their bowel management. It's a question of resources more.
Okay, thank you. We have one more addition to your story about ultrasound, Eberhard, from Sabine Hussen. She says that next to radiation dose, there's also more evidence for the use of ultrasound, and you get real-time information about the rectal diameter, and is useful as biofeedback. So I think that's a nice addition to your story.
Thank you very much. I fully agree. It's so beautiful to show to the child, oh, look at all those feces standing in line behind your bladder. That's causing your bladder problems probably, and they are waiting that you let them out on the toilet. It's so helpful for the children to see this, and it's very different from an X-ray picture you display.
Just one more question just came in. How do you deal with redo surgery in colorectal anomalies?
This is a question to the surgeon. So there is a nice work of Grassoff and Peña about the indications for redo surgery. One has to be very careful, and we would recommend to do a redo only after a finished multidisciplinary treatment, because either the situation gets better and you don't need the redo, or you have a better starting position for the child, because if the redo fails and the continence is not better or even worse, some children might get in very, very bad psychological situations. And to be able to help them with this disappointment needs a very stable relationship, and the psychologist should have the chance to see the child and work with the child and the family before redo.
Thank you. I would like to end with, well, that's not really a question. Well, it is a question. Someone is asking, constipation is incurable but manageable. Do you agree with this?
When I may answer, we don't really know the reason for constipation in anorectal malformation. We found some histologic changes, but not really explaining. And you know, the very complex, very hard forms of malformation, the rectovesical fistula, the high so-called cloacal form, they have very little percentage of constipation, and the low, not so bad forms, perineal fistulas, they have plenty of constipation, the highest rates. And I think the reason is that they have more muscles to contract, to fearfully contract the pelvic floor, not to let go, to keep it in. And so this part of the constipation can be healed by simply teaching them to let go. Then you have a certain percentage of the constipation is caused by the malformation. We don't know exactly why. And this part can only be managed, yes. But the functional part, it can be healed through MBT.
Thank you. Well, this was the last question. So for now, I would thank you all very much for your interesting presentations. And of course, everyone at home, thank you for joining us tonight. The webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel. And there you can also find links to the last webinars. I will send those links for tomorrow. You can also subscribe to our YouTube channel, and you can find the details of the forthcoming sessions on our website. Finally, if you have attended today, you will receive a survey immediately after the webinar, and we would be very grateful if you could spend a few minutes filling it in to help us continuously improve for the sessions. So for now, thank you all very much, and I wish you a very nice evening. Goodbye.
Thank you. Bye.